Okay. Hello, and welcome to Billing 201 for Behavioral Health Care. This is part 2 of our 4-part series of our webinar series that is focused on billing for behavioral health care and the issues that are associated with it. My name is Chris Williams. I'm the Marketing Director with the ECHO Group. And today, as I had mentioned, part 2 is snail mail versus the internet. We're going to take a comparison and contrast of the billing process if your organization bills using paper or if you execute your billing using electronic processes. We'll take a look at both of those and weigh the strengths and weaknesses of both. So here's the agenda for today. We'll go through, I'll share a little bit about ECHO, what we do. We'll talk a bit about the previous webinar series, Billing 101, introduce you to our speaker for today, and then we'll get into the meat and potatoes of our webinar, into the content. There will be time at the end for questions and answers, and then we'll look a little bit ahead towards next week's third part of our series. Just a little bit of housekeeping. You'll see in the right-hand corner of your screen an opportunity for you to ask questions. Just enter your questions there and hit submit, and as we get toward the end of our session, probably in about 20 minutes or so, we'll try to answer as many of the questions as possible. You can also reach out to us after the webinar if you have something specific, and we can have a conversation then about information you're looking to find. A little bit about the ECHO Group. For those of you who are attending a webinar that we've sponsored for the first time, the ECHO Group has been in behavioral health care for over 37 years, since 1981. We currently have partners in over 35 states, and we provide electronic health records, billing software, as well as billing services, revenue cycle management, technical services, and a host of other services related to supporting behavioral health organizations. One of our latest innovations is what we call our EHR RCO Partner Program. It's a program where we work with behavioral health organizations to eliminate upfront costs, fees, and also minimize the amount of revenue that's lost in the implementation process of an electronic health record. What we do is we work to have agencies up and billing within 90 days as we go through the implementation process. So if you have any questions about that or interested about that, you can reach out to us and we can have a conversation about our EHR RCO Partner Program. For those of you who are joining us who are existing partners of the ECHO Group, a reminder that our peer-to-peer summit, version 15, is in October in Portsmouth, New Hampshire. Every year, a large portion of our partners come together in New England in the fall for what I like to call 3 days of peace, love, and software. But essentially, it's 3 days of sessions and innovation with regard to our products, software, and services, but also conversations and networking and comparing notes with regard to what's happening in behavioral health on the whole. So if you're an existing partner of ours and haven't registered yet, there's still plenty of time. Registration is open. If you're not a partner of ours, peer-to-peer is just another good reason to consider becoming one. And for those of you who are joining Billing 201 for the first time, we preceded this webinar series with Billing 101, which was a 4-part series going over fundamental topics that are related to billing and behavioral health care. If you haven't seen or didn't participate in those webinars, you can see the link on the screen there and have access to that 4-part series as well and get that information. Onward and upward. Today's presenter is Suki Norris. Suki is the ECHO Group's Senior Knowledge Engineer. She's been with us since 1996, but has more than 35 years of experience in healthcare. She has an extensive background in Medicaid waivers, meaningful use, and the Excellence in Mental Health Act. She will be your presenter for the day and for the next 20 minutes or so. And so without further ado, I'll turn things over to Suki.
Thank you. Thanks, Chris. And good afternoon, everybody. So if you're involved in paper billing now or non-electronic, these are going to be some of the processes that you probably go through. You're going to have to manage your own billing rules. You're going to do some sort of eligibility check. Maybe you're looking up in the internet. Maybe you're looking at a client's eligibility card. You're going to document, maybe in a spreadsheet or some way, that there's an authorization, because you do know that you're going to need that authorization for billing. You're going to calculate charges, maybe through a very well-developed Excel spreadsheet, or in another manner, you're going to prepare paper claims. You'll get payments back, and you're going to get denials, which you'll have to review by going back through the previous steps to make sure they're all in place, looking at those records that you created and have stored in a way that is organizationally appropriate. You enter payments. You're going to resolve denials. You're going to manage appeals, manage your accounts receivable. You may do some patient billing, and then you're going to have to update your GL. Imagine, if you will, that you move to an electronic billing process. And as the slide moves, you're going to see how each of those boxes changes to rely on the electronic billing process. So while the same steps are taken, the reality is that there's a difference, because your partner is now your electronic health record. It has that data. It's going to store the data. It's going to process the data and help make the decisions that perhaps Excel, perhaps your billing person, was required to do before. And what I'm going to do now is walk through each of the elements on this to talk about, to help you understand how moving from paper to electronic allows you to use the system to support you in the work that you're going to do. So let's start with credentialing. What credentialing means is that you're going to have an electronic staff record. Your staff are going to be in the system, and you're going to have a record that you can maintain about their licenses, their credentials, the beginning dates, the end dates, the ability to, and the system will alert you when that's not there. Also, you'll be able to identify the credentialing. Are they credentialed to provide services for specific insurance or payers? Are they Medicare credentialed? Are they allowed to provide Medicaid services to private insurance? All of that's going to be maintained in the system so that when billing occurs, they'll be able to validate that you are billing for providers who really are allowed to bill that particular provider. And then finally, payers. You're going to list the payers that they are authorized for. The next is eligibility. This is a big one. If you're not using electronic methods for verifying eligibility, there's a disconnect between you are getting that information, either taking a copy of an insurance card or looking online and looking up on the internet to see if there's eligibility. To verify eligibility in an electronic system, you can use an accepted format, the 270, 271 transaction, to electronically send to payers, and they will send you back verification of eligibility, either that there is eligibility or not. And many payers will say that if you have that eligibility with the electronic verification code that they send, that will allow you, if there's a denial for eligibility, to fight that denial and really turn it around to be paid. Prior authorization. I'm certain that in the Medicaid environments that you're in, many of you, whether it's a private payer or public payer, are dealing with requirements for service authorizations. When you have those service authorizations in your system, you get to do a couple of things. You can keep your clinicians alerted that the service authorizations are in place. So they will know that as they provide the services, those service authorizations are there. You can even have a check at the time you're entering a scheduled activity to ensure that the authorization for that activity is in place, and get a warning, let's say, that there's a missing authorization, to let your front desk begin that process of getting a reauthorization or an additional authorization. In an electronic system, you can identify the insurance companies that require authorizations, but you can also use the system to identify services that do not require authorizations. So you may have a situation where the initial assessment may be able to be done without an authorization, but all subsequent activities require an authorization. With an electronic system, you can actually tell the system which services require auths and which don't. And then finally, your clinical system can represent that authorization so that anybody who's working with that client will know what the status of the authorization is. Charge posting. This is a really important, this is a true differentiator between paper claims and paper processing and electronic processing. With electronic processing, all of the edits that will create a clean claim can be part of a process that's where the system is going to look at the data and validate the data against the rules that are in the system. So what it's going to determine is, can the services that were entered be billed to a particular payer? Does the provider have the right licensure? Do we know that is there a charge amount? Or is there a critical error that should keep this off of a claim because it's not clean, it's not going to be paid, it's going to be denied, or it may cause other problems? It can produce warnings that while you can bill for this service, perhaps it's missing an authorization, or one of the payers is missing an authorization. One of the real values of electronic claiming is you know that many of your clients have more than one insurance. What an electronic system will do is it will automatically waterfall. So as the first payer pays and that payment is processed, it will automatically waterfall to the next payer without any activity. So you don't, if the system maintains the information, the system will automatically move that charge along. And all of that is done as part of that charge posting process. Once it's posted, the system's going to know who are the payers for this, how much is charged, who did the service, and who should be the next payer in line to be responsible for that charge. Claim submission. Well, right now, if you're doing paper, you're going to be sending a piece of paper or several pieces of paper to payers. Could get lost in the mail, could get eaten up by a postal machine. When you do electronic claiming, you're going to be sending an electronic file to a secure site, a state site, a private payer site. And one of the things that's well established is that electronic claims are paid faster because there is no human intervention on the payer side to have to enter that claim, to have to process that claim, to deal with any errors that may happen within the claim entry. And an electronic system can still create, if appropriate, a CMS 1500 or a UB04, but you get the advantage of the edits that have been applied to that service as it's moved through onto the claim. And again, you can still do patient statements where appropriate. Payment posting. Right now, if you're doing paper claims, you're getting an EOB back from a payer, or you're getting a check back, and you're going back through your records to figure out what charges you have outstanding. And you're going to apply that payment to those charges. Maybe the payer has laid out in a very clear way which services that they're paying with the check, or maybe they haven't. And maybe they've denied some, and you're going to need to work that denial before that charge becomes available to be charged to anybody else. But if you bill electronically, you're going to get your payments back electronically. And when you get those payments back electronically, you can post them into the system. And at that point in time, there's really the only human intervention has been to grab a file and to put that file in the system. The system will go out and match the charges. The system will record any denials. The system will take care of the things that with human intervention can both take time and also introduce errors. You get denials. Well, a certain amount of denials is going to be, it requires human intervention. There's no doubt about it. But with an electronic system, you can identify the denials, you can track the denials, and you can review and submit denials. And there's one more piece that isn't here, and that is you can report on denials across all payers to see if there are areas in your billing department that need to be addressed, or areas within your clinical staff that need to be addressed, because you'll find, are there trends in your denials? Maybe they're all one-offs, but you may find trends that will help in to make training decisions, to help in data entry decisions. So with having that data electronically, you'll be able to report out those kinds of trends that might help you in the future get your claims even lower denial rate. You're going to be waiting payments, but with an electronic system, you're going to reduce your receivables because you're going to get paid faster. Your claims are going to be cleaner, which means your denial rates are going to be much less. When a clean claim is a claim that can be paid as is, that the system, the state system, the Medicaid system, Medicare system finds no errors in and pays it. And then you can also do on-demand reporting. Just as I said before, when you have an electronic system and you've got accounts receivable, you can locate those accounts receivable on demand because they're all stored electronically. You're not going back into some file to find them. You don't have to search through items on your desk. They will be in your system and available for reporting and reviewing. Patient billing. The advantage here is that you've got your electronic data and you're going to electronically generate those statements that would go to the patients. Ultimately, there'll be a piece of paper, but by having all the accuracy checks that are involved in an electronic system, the likelihood is you'll have fewer patient calls because those patient bills will be more accurate, and you'll be able to manage them, determine which ones need to get written, and be able to do it systematically as you look at your data. And in an electronic system where you if you collect co-payments, you can put them in at the time of service entry, and they will be a part of that client's record as that record is billed and processed. So you'll have that, you'll always have that ability, because of the electronic system, to sort of keep track of those and make sure that the client is credited with what the client has paid previously in a copay. GL and month-end reports. If you're doing paper claims, then you're probably having to manually post to your GL, which means that you're going to, again, you may risk errors in the posting. It's going to be time-consuming and labor-intensive. If you use an electronic system, well, that electronic system can output a file to be uploaded into your GL system that has the same accuracy as the data in the electronic system. You can create month-end reports with the push of a button for your senior staff to look at, for you to look at, to see how you are, the health of your agency. And you'll be able to track all the transactions that have posted over time, so that if you have to resend or recalculate a claim, reprocess a claim, the system will know that that is an adjustment to a prior period as opposed to some new account receivable, a GL post. So it will give you more accurate reporting to be done both in your system but also in your general ledger system. But what's the real value? And what you see in front of you now is the real value. If you spend the time using an electronic system, all that data is stored in your system. When you store data, you can report data out. If you're doing manual claim entry and you're capturing all that data by hand, getting to this kind of data that you see in front of you becomes difficult. But if you're doing an it's time consuming. You may have the data, but it's going to take you time to get it. And because your claim system is it changes all the time, it's always going to be a little bit out of date, a little bit out of sync with where you are with data, with payments, with claims, etc. When you have an electronic system, you can have real-time financial reports with the push of a button, including dashboards like you see in front of you. You can look at what's been the total billed, how much have you billed by program, by hours, who are your top payers. You have the ability to see this data for yourself, for your senior managers, to see data with the push of a button and be able to really calculate the health of the agency on demand without IT helping, without anybody trying to pull data, just by pushing a button. So what does it all mean? Well, to go back to sort of what we've talked about, if you do paper billing, then you're going to have clinical services that are put on a paper chart. They're going to have to be manually entered and manually billed, which takes time. And then you're going to have to mail them to the payer, which adds risk to it because they could get lost in the mail, they could get damaged. They'll go to the insurance company, they'll have to go out to the bank, and then you're going to get paid, but you're going to get paid at a slower rate and probably at a lower rate because your denial rate is going to be greater because at every step along the way you have the possibility of introducing unintended human errors. If I move to electronic billing, then we can see the same thing. I have a clinical service, it's going to be entered into the electronic record. So there's no handoff here. It's entered in contemporaneously with that service being provided. In very little time, it's going to go into billing and going to be submitted electronically to the insurance company, and you're going to get payments back, and your denial rates will probably be reduced, resulting in a more timely return of cash for the health of your agency. It isn't that people haven't done paper charts and paper billing for a long time, but with an electronic health record, with adoption of electronic health records, you can reduce your denial rates, reduce any unintended errors, and speed up the processing of the claim and the recovering of dollars from the claim. So at that point, if there are any questions, I am happy to address.
Thanks, Suki. We do have a couple of questions. First, as you compare and contrast paper and electronic billing, are there payers out there that are, while they may prefer electronic billing, that are moving away from accepting paper claims altogether?
Yes, I think you'll find state Medicaids are, Medicare are, many of the MCOs, as they come into states, will indicate they'll either say we won't take electronic billing, or they'll say we will guarantee a turnaround of X days for electronic billing, and if you still do paper, it's going to be X plus several weeks. The mid-ground of this is that there are places, I know that there are counties in the country and others that are saying, all right, you don't have to submit to us electronically, but if you're not going to send in an 837, you will have to do direct data entry into our portal because we won't accept a CMS 1500 or a UB04. So they're moving to requiring electronic, but they haven't gotten there quite yet. Probably you'll see it quite likely in the next few years where it's either going to be direct data entry or electronic claiming.
Okay. If a claim is denied and the appeals process has been exhausted. At what point do you recommend to write it off? And I would imagine this is for electronic or a paper process. And how many days in aging should we cut our losses?
That's really, I think the question is going to have a twofold answer. If a claim is denied and you have exhausted the appeal process, whatever the time frame for that claim is probably going to control how long you really want to go through the appeal process. So if you have 6 months to put in a claim and you're at 8 or 9 months, the likelihood is you're not going to get any further. It also depends on the type of appeal, the type of denial, as to what you think the likelihood is. Because I will say that I have seen in my time a concerted effort to force denials to avoid the transfer of cash. So if it's a one-off denial, I'd say the timely filing is good. If you're seeing a block of services denied, then I would stay with them until it could be a year later, but that payer is going to have to come around and pay, because the likelihood is that the denials are more for their cash flow than because of actual invalid or deniable services. And as far as how long or until you write off again, I think that's an agency level decision. I think every agency may do it a little differently, but what their board expects, what they expect. I don't think there's a one-size-fits-all.
Okay, so in working to stay on top of those claims, again, regardless of whether it's paper or electronic system, well, actually, in this question, how many days or how long do you recommend, how much time do you recommend allowing to go by after you've submitted a claim electronically before you start following up if you haven't heard back?
If it's the first time you've submitted to a payer electronically, I'd follow up within a couple of days. Make sure they got it, make sure there are no problems, make sure there's nothing that they've sent you that you don't know about. If it's somebody that you've worked with for a long time, if it's past the usual and customary time that you've experienced and you haven't heard from the state or from the payer that there is a reason for it, I would call them at that point. So if you usually get a return in 2 weeks and you're at 2.5 weeks, I'd make a call or I'd follow up with there is an electronic transaction you can send, but I would do one of the two and find out. Because if it's an aberration and there's a system problem, you want that information for your agency. You may know it's going to pay. If they say we'll pay but not for a month, your executive director is going to want to know that there's going to be a delay in reimbursement for what could be a significant amount of money.
Okay. If clients don't have a copay, but co-insurance out-of-pocket liability, do you recommend collecting something at the time of visit or wait until the organization gets paid and then send a statement?
What I have heard from the various folks I've dealt with over time is that the best opportunity you have to receive payment is when the client shows up for a service. That patient statements in the populations that most of our partner agencies work with don't have a high probability of payment. It also depends if there are legislative mandates for payments. It's a drug and alcohol program where you have to have a payment. Medicaid requires a payment. In those instances, to save yourself, I would get those payments up front and not wait. If you wait, you probably have a less likelihood of collection.
All right, that's great. That's about all the time we have right now. It's coming up on 2:30 here in the East Coast. For those folks who have submitted questions and we weren't able to address it here in the webinar, we will follow up with you personally or individually to respond to that. A reminder that this webinar has been recorded and the slides and recording will be available to you online at some point tomorrow. You'll receive an email from us. Also, stay tuned for part 3 next week. July 20th at 2 p.m. Eastern Time. We're going to take a look at how to assess and improve your billing process on the whole so that you can become more efficient within that in your system. So until next time, have a great weekend, and we'll talk to you next week. Thank you.